Thank you, Sri Priya. Good afternoon to all. Happy to see you again. As Sri Priya said, today we are going to discuss on gastrointestinal symptoms. The session will be taken by Dr. Greeshma, who is a palliative care physician, and she has around 2 years of experience in palliative care. So, ma'am, welcome and about you.
Thank you, Sri Priya, and thank you, Sister Shiva. Good afternoon, all of you. Yeah.
Good afternoon, ma'am.
Good afternoon.
Yeah. Today's topic of discussion is GI symptom management in palliative care. Yeah, we will see. Today's main objective is to identify the common GI problems in palliative care, and we will be dealing in detail the management of nausea, vomiting, and constipation. Before starting, we will be seeing a case, and at the last, you all will be answering to these questions. So please, we can go through this case. A 55-year-old frail lady who is diagnosed with gastric carcinoma and now on chemotherapy was admitted in general ward for treatment of urinary tract infection. And she was admitted with vomiting, abdominal colic, and fever. Now she is tired and has admitted for completion of IV antibiotics. And she has small, frequent, incomplete bowel movements for 4 days. And he started today on laxatives, and she is accompanied by her younger doctor. And what are the issues here, and how would you investigate, and how would you manage? All of you can go through this. Okay. First, we will see what is emesis. Can anyone answer what is emesis? It is already on this, but I would like to make it some interactive session. So what is emesis? Please share your knowledge on what is emesis.
Like anything which is not accepted by the gut, so that has been thrown out. What we call it as vomiting.
Yes, ma'am. Thank you, ma'am. Yes, as she said, it's a biological defense mechanism to remove toxic or harmful substances from the body after ingestion. And we might have seen patients coming to our casualty or in our OP in our day-to-day practice with opioid poisoning or food poisoning and all, right? So this is a biological mechanism to remove this toxic substance from our body. Okay, and the process of emesis is in 3 phases: nausea, retching, vomiting. What is nausea? Nausea is an unpleasant sensation of the imminent need to vomit. We all have experienced this nausea before, right? We will have an unpleasant sensation that time, and we will know, yes, we want to vomit, like that way. It is a sensation to vomit. And next thing is vomiting. Vomiting is a forceful expulsion of the gastric contents through the mouth. It is associated with contractions of the abdominal and chest wall musculature. So we know when we vomit, the intra-abdominal pressure will increase by the contraction of the abdominal muscles, along with the contraction of the respiratory muscles, the chest wall musculature. The gastric contents will be expelled out through the mouth. Okay. And retching, it is a spasmodic respiratory movements against the glottis with contraction of abdominal musculature. It can be with or without expulsion of gastric contents. Okay. Hope it's clear for all of you. Then we will see the types of vomiting. First, acute vomiting. Acute episode is that occurs within 24 hours. For example, a patient who is undergoing chemotherapy when a patient is on chemo, the vomiting may start within 24 hours. Okay, that is acute onset of vomiting. And the second is delayed vomiting. Delayed means after 24 hours. That can again happen with chemotherapeutic agents. And will start after 24 hours, can last for 6 to 7 days even. And next thing is breakthrough vomiting. Breakthrough vomiting, we know with chemotherapy as well as in many cases, there is a chance for vomiting. For example, in case of this opioid, when a patient is on opioid, there is a possibility of vomiting, right? So we may give some antiemetics along with that before starting chemo, or before along with starting a opioid, we may be starting an antiemetic as well. But despite this antiemetic treatment, if the patient is vomiting, that is breakthrough vomiting. Okay, and refractory vomiting, it is even with many other medications for vomiting, the patient is still the patient still has vomiting, and the vomiting is not controlled with 1 or 2 antiemetics. So that is refractory vomiting. And last one is anticipatory vomiting. For example, if the patient is posted for chemotherapy coming weeks or coming months, or they are posted for any investigations. For example, they have diagnosed with a mass in the abdomen, and after consultation, doctor has advised some investigations for them, or after they are posted for a chemotherapy. So they may be anxious. I have seen patients in our ward here, they will be very anxious, and they have these symptoms of constipation, vomiting and all. And when we are dealing with history, we will know tomorrow or day after tomorrow or next week, they will be thinking about all these things, and they will have all these symptoms. So we should we should take the history properly, and from that history, we can identify this anticipatory vomiting. Okay. Why is it important to control this vomiting? Can anybody answer?
Prevent dehydration.
Yes.
There will be loss of some electrolytes.
Yes, of course. Any other thing we are concerned when a patient is presenting with vomiting?
Weakness.
Uncomfortable for the patient.
Yes.
Patient will be very weak.
Yes. As you all said, all these factors are there, along with the many other factors too. So first, it affects the patient's daily functioning, right? And second thing, it hinders the quality of life. When a patient have any symptom, pain, vomiting, constipation, or respiratory distress, or any symptom when a patient presents, it totally affect the daily functioning as well as hinders the quality of life. And the second thing is the non-compliance to treatment. Okay, we may be giving some medications orally for pain management or some other symptom management or for curatory purpose. The patient may be on some oral medications, but they may not be able to take those medications orally because of this vomiting. Okay. So there is a compliance issue as well. And inadequate symptom control. Fear or anxiety, poor absorption of medicines, yes. And then escalates distress. Patient and family will be also be in distress. Why? Why the patient and family both are affected? When a patient is in vomiting, most of the patients coming into us in palliative care are taken care by their caregiver, right? So when they are vomiting repeatedly, when there is multiple episodes of vomiting, they have to change their dress, or there will be smell, and they cannot even take the food properly, and it will be totally affecting the patient. They, as you all said, there will be dehydration, but even they couldn't even take a sip of water because of this vomiting. So it is a very disastrous symptom, and that should be managed as far as possible. Okay. Please. What are the causes of vomiting? Please answer. What are the causes you have seen in your day-to-day practices?
Indigestion.
Okay.
Poor absorption.
Yes.
Any gastric disorders also.
Yes.
Some infections.
Yes. Yeah, we can move on to the next slide.
And so,
Yeah, there are many causes, right? We might have seen all these cases in our practices. First thing is chemically induced nausea. We have seen drugs, opioid induced vomiting we have seen in our wards, and antibiotics induced. Did anyone see this opioid induced vomiting? Okay. Can anyone tell a name of an antibiotic which causes vomiting? Usually presents with vomiting. Patient may be presenting with vomiting with along with the antibiotic.
metronidazole,
Yes.
cloamoxazole.
Yeah. Yes. Ciprofloxacin. All these can cause vomiting, right? And cytotoxic drugs. We have already told chemotherapeutic agents that can cause nausea and vomiting. How it is causing vomiting, we will see in detail in coming slides. Okay. And food poisoning, we all have seen, and metabolic organ failure, gut obstruction, all these can cause vomiting. And gastric stasis. Some of the drugs which we are administering can cause gastric stasis. One of the example in palliative care is opioids and anticholinergic drugs. We will see that in detail in coming slides. And peptic ulcer, gastritis, when the patient is having stress, anxiety, or some drugs can cause gastritis, NSAIDs can cause gastritis, radiation, all these can cause vomiting. Okay. And stretch or distortion of GI tract, intestinal obstruction, constipation, mesenteric meds, all these can stimulate the stretch receptors of the GI tract and thus cause vomiting. Okay. Serosal irritation, liver mets, ureteric obstruction, irritation of GI tract, infection, it can be NSAIDs, drugs, and raised intracranial pressure. What is the first sign or what warning sign we see in a patient with raised intracranial pressure?
Headache?
Excuse me?
Having headache?
Yes, headache will be there. There will be projectile vomiting, right? So type of vomiting is also important. And raised intracranial pressure can cause vomiting, cerebral edema. There may be a mass or a space occupying lesion or intracranial bleeds. We know the patients with intracranial hemorrhage presenting us with headache and vomiting, right? And also in palliative care, there are patients who are presenting with severe headache as well as there may be associated symptoms like loss of memory in a patient with mass effects. Okay, mass in brain and movements associated. We all know about motion sickness or morning sickness, right? There will be vomiting. That is due to the vestibular disorders. Okay. And anxiety-induced vomiting. Anxiety can cause vomiting and anticipatory. We have seen in simple case, even the exams, the fear of exam can cause nausea, right? How many of you experienced this before? Nobody has experienced that. I myself.
Diarrhea.
Okay. Yes, yes, definitely. It can happen. It will increase the secretion in the GI tract and that can cause diarrhea. And this increased secretions can also stimulate the vomiting pathway. Okay. The next. And other important causes of upper GI issues in palliative care. Oral thrush. How many of you have not seen oral thrush so far? I hope everybody knows about oral thrush and how it can be managed and what are the oral care we advise to the patients with the oral thrush. I hope it's clear for all of you.
Yes, ma'am.
Yes.
Okay. Yeah. We are dealing with patients who are immunocompromised, right? So this oral thrush is very important. We are dealing with the GI symptoms. So this oral thrush is very important. It's a patch, right? It's a white patch. It may be coated on the tongue, hard palate, soft palate, can be anywhere. So we should thoroughly examine the oral cavity, and oral care should be given, as well as if there is a need of antifungals, that should be given topically. If it is severe, then should be given systemically as well. Halitosis can happen, as well as mucositis, dysphagia, dyspepsia, hiccups, everything. These are the symptoms mostly seen associated with upper GI tract in palliative care. How we will choose an antiemetic? First thing, we should identify the cause. Okay, then we should identify the pathway which triggers the vomiting reflex and identify the neurotransmitter involved, as well as we should choose the potent antagonist, the receptor identified, and we should choose the route of administration, and we should titrate the dose, monitor the patient, and administer regularly. Okay. What are the objectives? What are our objectives when a patient is presenting with the vomiting? Okay, what will be your primary objective when a patient is presenting to you with multiple episodes of vomiting? Maybe 10 to 12 episodes of vomiting.
Reduce the vomiting.
Yes, of course.
And prevent dehydration.
Yes.
And prevent imbalance, electrolyte imbalance.
Yes.
And nutritional support also, the patient will lose the nutritional support also, no? That's
Yes.
also will have to prevent the starvation, like something.
Yes, ma'am. Thank you, ma'am. And all these are important. Okay. First thing is, when a patient is presenting to you with multiple episodes of vomiting, either in home care or in ward or in OP basis, wherever it is, our primary goal is to reduce the vomiting, at least the frequency. If we can stop the vomiting completely by giving an antiemetic, it is really appreciable. But at least we should reduce the frequency, right? And to establish the compliance of treatment, I have already told there he or she might be on many oral medications, so it will affect that also. So we should ensure whether it is affecting the intake of other medications at regular intervals, or all other symptoms may also exacerbate if they are not taking these medications on proper time. Okay. And yes, to improve the quality of life. These are our primary objectives, and we should check on to the dehydration, nutritional part, everything we should check on. Yeah. The principles of management. First, you might have dealt with other symptoms of palliative care. In palliative care, you might have seen not only in palliative care, in any case, we should correct the correctables, right? We should correct the cause. First, we should identify the cause, and we should correct the cause. It can be done. Non-pharmacological measures are there, and pharmacological measures are also there. In case of vomiting, there are many dietary modifications as well. What we are doing is, we are identifying the cause, and we are identifying which pathway of vomiting is stimulated, and we are identifying the receptors involved, and we are giving this antiemetics accordingly. Okay. Next. First, non-pharmacological measures. Yeah. Can anybody answer this? What are the non-pharmacological measures?
Positioning.
Yeah. Positioning can be done. When a patient is being vomiting repeated times, we know some situations will promote or provoke nausea and vomiting, right? The smell of
Change the environment.
yes, changing the environment or calm and reassuring environment that can be assured. For example, avoiding situations which induce nausea and vomiting. For example, the presence of a dustbin inside a room. Okay, or the vomitus, the previous vomitus particles may be there in the room or in the surrounding or in the bed sheet, or all these can stimulate further vomiting episodes. So all these are important. Okay, we should avoid such situations, or the smell of cooking foods. Okay, then we should ask the caregiver to close the doors of kitchen while cooking and open the window to get fresh air, and all these can reduce the episodes of vomiting if that is the cause of vomiting. Okay, and nursing in the upright position. Next, good oral hygiene. Some may be having halitosis, so this foul smell itself can cause nausea and vomiting. Okay, or somebody may be having this colostomy or fungating tumor even in the oral cavity or in the mandible or surrounding, or maybe in the breast. All these can affect the episode of vomiting. As well as in our wards, we have seen usually in our wards we used to isolate the patient who has this foul smelling maggots and all. Okay, foul smelling wounds or maggots. Why? Because the patient himself or herself may know it is causing distress to other patients and caregivers. They may be worried regarding that as well. Okay, so what we should do is, if it is bothering the patient, then we should make them okay by doing some arrangements. Okay, if it is small order, you might have see how the wound management is being done. If it is not taken, you all will get that session in coming weeks, and suitable distractors that can be also be done. Next. Distractions we usually use when there is anticipatory vomiting. Why? Because the patient may be very anxious, thinking about the diagnosis or the prognosis, or sometimes it may be due for any investigations, or maybe thinking about the chemotherapy, radiation, how it will be. I have seen one patient in our ward. She was very anxious, thinking about FNAC procedure. The doctor has suggested FNAC. So she already underwent FNAC before, so she know how painful it is, and she was just crying and she was very anxious and she was having these symptoms. And so what we can do is we can connect her with a psychologist. So they will deal with this. They will do self-hypnosis. They will advise them with self-hypnosis or progressive muscle relaxation, biofeedback, systemic desensitization. These techniques they will advise. Okay. Sometimes, along with an antiemetic, we should do this distraction technique as well. And all these will help to enhance the feelings of control and will reduce the feelings of helplessness. Okay. Next. And what are the dietary modifications we can suggest to a patient with vomiting? Usually when a patient is coming to us with fever, what we will advise? Do we advise biryani for them?
Take oral fluids, lots of oral fluids.
Oral fluids. And what type of diet we will advise?
Light, semi-solid, like something frequent times, small quantity.
Yes. First thing, this smell of these foods itself can cause nausea and vomiting. So we should take the history in detail. The history taking has very important role. So we should ask the patient, okay, when this vomiting comes and what are the reasons for this vomiting? If the smell of a food or something is making them nauseated, then we should ask the caregiver to avoid that. Okay. And instead of giving this large meals and huge meals in 1 or 2 times, in spite of that, we can advise small frequent meals. In diabetics, we advise the small frequent meals, right? Like that way, we can advise small frequent meals. And mostly, we can prefer them to take food mostly during the daytime in the breakfast and lunch. Okay. And never force them to eat. That is the one thing. Okay. There are caregivers who's very worried because the patient may be having multiple episodes of vomiting and she's not taking anything. She doesn't take any didn't take any food yesterday also. The caregiver may be telling you like that, and they may be forcing hers or her mother or a relative to take more food because of the concern. But this overfeeding can also cause vomiting. So we should check on to that they are not overfeeding the patient. Okay, we should tell them it is not helping him or her, it is adding distress to her. Okay, we should give proper caregiver education as well. And we should ask them to avoid fatty foods and sweet, spicy foods, which can increase the secretion in the GI tract and in turn cause vomiting. So carbonated drinks, all this can be avoided. And eat foods that are easy on the stomach to digest. Okay, easily digestible foods we can advise when the patient is having vomiting. Okay, next. What else we can do is keep the mouth clean and do oral care after each episode of vomiting, and to wear loose fitting clothes and have fresh air with a fan or open window, and limit sounds, sights and smell that causes nausea and vomiting. That is mainly with this anticipatory or anxiety issues and all. And give contact information if nausea vomiting is not controlled. We should make them feel that we are with them. Okay. If a patient you are seeing in home care, then you can give the contact number if it is possible. Okay, if it is possible in your settings, you can give the contact number so that they can contact you if the vomiting is not controlled. Okay, we are dealing with the palliative care patients, and most of the patients are bedbound or bedridden, or there may not be any adequate caregivers and all to bring him or her to hospital frequently. So if they are being given a contact number or something like that, they will feel happy and they will feel considered. And that itself can reduce the symptom. Okay, next. And then coming to the pharmacological measures, I would like to hear from all of you. What are the medicines you already seen for vomiting management? What are the antiemetics you? Okay.
Metaclopramide.
Yes, metoclopramide or ondansetron. Then
Injection hemicid.
Mortilium also, no, the domperidone,
yes,
Injection hemicid.
yes,
amdaspetlin,
yes,
Injection nausea.
yes, of course. Then, okay, when this metoclopramide is being used most frequently in palliative care?
When we are giving oral opioid, before
Yes.
that,
Yes. And ondansetron or emised when it is being given in palliative care?
when the ondansetron is not answering, we can use the Maxalon or something, no?
Yeah.
Oh.
All these we will see in detail.
Both we can give both together or?
Yeah, we will see, ma'am. We will see. Okay,
Okay,
thank you. Thank you for the response. Next. There are 5 players. Okay, these are the These are the centers which will be stimulated for causing this vomiting. Okay, there are 5 centers. First thing is vomiting center, which is located in the medulla, and adjacent to this vomiting center, there is area postrema or CTZ, which is also located in the medulla, and there is vestibular nucleus and GI tract and cerebral cortex. Okay, there are multiple receptors associated with this centers, and the stimulation of these receptors will evolve a pathway. Okay, and ultimately it will stimulate the vomiting center and will cause vomiting. Sri Priya will be sharing a video so that you all will get a good clarity on this. Okay, after that we will, if you got an idea. I hope it's clear for all of you. And next. Yeah, there are 5 centers. Next. 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 Yeah. You all have seen these centers, right? I think some of you are confused now. What is happening with vomiting? Okay. To get a more idea, I'm just, this is very important. That is why I would like to okay, I would like to repeat it again. So there are 5 centers in this picture. We can see the gut wall, area posterior CTZ, and cerebral cortex, vestibular nucleus, vomiting center. All these 5 centers has multiple receptors on this. Okay. For example, in chemotherapy, you can see it will stimulate the 5H3 receptors in the gut wall as well as CTZ. You have seen in the video as well. That while we are giving this chemotherapy, the chemotherapeutic agents can stimulate the endochromaffin cells has this 5H3 receptors. So these receptors get activated in the gut wall, and again it will be transmitted through the vagal nerve to the area posterior or CTZ. So both these centers are stimulated. Not centers as such, these receptors are stimulated. So in chemotherapy, while we are choosing an anti-emetic, we prefer a 5-HT3 blocker. Okay, which is a 5-HT3 blocker? Can anyone answer? You all know, you already told. Some of you have answered that. It is ondansetron. Okay, this is cetrons. Okay, 5-HT3 antagonist. So that is the reason why we are giving ondansetron or Emisset, this is most common name in chemotherapy. Okay, we don't prefer metoclopramide in a chemotherapy induced vomiting. Why? The receptor that is involved is 5-HT3. Okay, so we should give an antagonist to 5-HT3. And second thing is morphine. We all know when we are giving morphine or when we are prescribing morphine or opioid, we should give an antiemetic, right? We prefer a D2 blocker. In this picture, we can see this morphine or any other opioid that will stimulate the D2 receptor. The morphine also acts on the mu receptors. Okay. The morphine acts on D2 receptor in the area posterior or CTZ, as well as it will act on the mu receptors on the vomiting center. And it will also stimulate the GI tract as well as vestibular nuclei through others by causing this stasis and all. Okay. So mostly we prefer metoclopramide due to the action on D2 receptor. Metoclopramide is a D2 antagonist. Okay. That is the reason why we are giving this metoclopramide in case of this opioid-induced vomiting. Hope it's clear. And haloperidol can be used because it has an action on mu as well as these receptors. And domperidone has also an action on D2, but we are preferring this metoclopramide. Why? Because the morphine has some action on the gut. It will reduce the bowel motility, right? So it will cause a stasis. The metoclopramide has a prokinetic action as well. Okay, so it has a dual action as an antiemetic as well as prokinetic. Okay, so better to give this metoclopramide while we are giving this opioids. And in case of uremia or hypercalcemia, this D2 receptor is being involved and we prefer D2 antagonist. And coming to the cerebral cortex, you can see the fear, anxiety, raised intracranial pressure. All these things are there, and when there is raised intracranial pressure, it will stimulate these receptors there and will induce vomiting through the vomiting center. So what we prefer is to reduce the intracranial pressure. We prefer steroids. You might have seen patients being given steroids. This is the reason why they are prescribed with steroids. Okay, what is the action of steroid? Most common action. What's the mechanism of action of steroid?
Cortisone related something that.
Yeah, it is there.
And GI tract and the connecting the vagus. Now that video shows now that.
Yeah, we will see that in detail, but yeah, in coming slides, it is already there. I will explain it here itself. The exact mechanism is not mostly known, but it has an anti-inflammatory effect, right? When there is an edema or when there is an inflammation, we use ointments and creams which has the steroid contents. Why? That is an anti-inflammatory effect, right? That is the reason. So when it is being given in particular dose, that will reduce the edema, that will reduce the intracranial pressure, and also that will reduce the permeability of the blood-brain barrier. Okay, so the emetogenic substance will not enter or cross the blood-brain barrier and affect the cerebral cortex. That is another reason, and that will also reduce the GABA. Okay, that is another reason, and also it will reduce the secretions and all. Okay, these are the reasons why we prefer steroids in these cases. Okay, and in case of fear, anxiety and all, what we can be given? What can be given? Suppose a patient is coming to you with severe anxiety and all, what you will give? Usually what you have seen?
Haloperidol.
Excuse me?
Haloperidol something, no?
Yeah, haloperidol can be given, but mostly what we prefer?
Amitriptyline.
Amitriptyline, yes.
Yeah, amitriptyline, that is an antidepressant. This haloperidol is an antipsychotic. Yeah, severe
Midazolam.
anxiety, severe
We give
restlessness, we give
midazolam.
this. Sorry?
Midazolam will give.
Yeah, what is midazolam? That is a benzodiazepine, right?
Yeah.
That is an anxiolytic agent. That is an anxiolytic agent, right? So that can be given. Benzodiazepines can be given in fear, anxiety, etc. Lorazepam in low dose 0.5 milligram OD or BD can be given. Okay. In palliative care, we used to see the patients having this fear and anxiety regarding this chemotherapy or any investigations and so on. So when a patient is having these symptoms, when a patient is very anxious on an event which is being on the next or coming weeks or months, so if their anticipation is causing this nausea or vomiting, then we should give an anxiolytic or benzodiazepines. Okay. Even before starting this vomiting, we can give to reduce their anxiety. Okay. And for chemo, if the patient is being posted for chemotherapy, we know, yeah, of course, the chemotherapy, after starting chemotherapy, the vomiting will start. So before that, we can start as a prophylactic. Okay. As well as in opioids, I already discussed that. And coming to the vestibular nuclei, there is muscarinic receptors as well as histamic receptors. So some of you might have experienced this motion sickness while traveling. Okay, why it happens? It affects the internal ear. The ear has 3 parts and mostly the labyrinth, which is associated with the balance and all, is when it is being affected. We know Meniere's disease and all, right? So some in vestibular disorders, this vertigo, this nausea, vomiting symptom can occur. So mainly the vestibular nuclei is stimulated through muscarinic and histamine receptors. So we should give medicines for antagonizing these receptors. Okay. Can anybody say an example of motion sickness? Which medicine is being given usually? Or all of you might have know this.
Stemital, ma'am.
Uh,
Stemital.
yeah, stemital. Yes. Any other?
Abdomen.
Yes. Yeah, we will see in few further slides. And vomiting center, we are okay. All these other centers, gut wall area, prostrema, cerebral cortex, vestibular nuclei, all these can stimulate this vomiting center and can produce a reflux and cause nausea and vomiting. Okay.
Doctor, what about
Promethazine.
promethazine?
Yes. We will see in coming slides. Next slide. Okay, this I already explained. What happens in chemotherapy is the release of serotonin from GI ball and by the serotonin 5-HT3 receptor. Okay, 5-HT3 is that receptor will be stimulated in the CTZ as well as gut wall and cause vomiting. Next. No. What happens in the gut is there are many receptors. The chemoreceptors are there, as well as stretch receptors are there. There's gastric stasis, as well as this gastritis, everything. The secretions will be more. The histamine, when the histamine is being released, there will be more secretions and all. We used to give antihistamines in that case. Okay. If the chemoreceptor is the agent, then we should give 5-HT antagonist. If it is histamine, if it is due to some NSAIDs, or if it is due to peptic ulcer or stress, if it is like that, then we should give antihistamines. And this increased secretion, which is causing this, then we can give this anti-muscarinic agents can also be given. Okay, next. And opioids, I already told, D2 receptors as well as mu receptors are involved. We mostly prefer metoclopramide. Okay, next. And pharmacological management, these are the medications. Okay, some of you have answered. Anticholinergic hyoscine butyl bromide. Okay, that is an anti-secretory effect, and that is an action on this ACH receptor you have seen in vestibular nuclei. Okay, so this motion sickness, we can give this hyoscine as well. Okay, hyoscine butyl bromide can be given in motion sickness. And another receptor involved is H1, yes, H1 receptor. So antihistamines, promethazine, some of you have answered, right? This can be given. Other medications you can go through, diphenhydramine, dimenhydrinate, everything, doxylamine, meclozine. Then B2 blockers, metoclopramide we have seen, chlorpromazine and others. And prokinetic drugs. I have already told metoclopramide has dual action of prokinase. It acts as a prokinetic as well. So when there is stasis associated with those opioids, it will help the evacuation of the bowel. Okay, so you should be cautious. Here we are dealing with two medications. Hyoscine, which is coming under anticholinergic, and metoclopramide, which is coming under prokinetic drug. Okay, we know hyoscine, which is Buscopan, you might know. The content is the hyoscine butyl bromide, and that has an antispasmodic effect as well as anti-emetic. That is an anti-emetic property as well. Okay, but this hyoscine and metoclopramide should not be prescribed concurrently. Why? One has prokinetic action and other has antispasmodic effect. Okay, the both this contradict each other. So keep in mind this. If any doctor is prescribing this like this, you can give a suggestion. Okay, I'm just reminding that now because both these medications are being shown in the same slide. And coming to 5-HT antagonist, that is we already seen ondansetron, granisetron. Mostly we give ondansetron, AMZ. And adjuvant antiemetics. Adjuvant antiemetics we have seen benzodiazepines as well as steroids. Okay. And antipsychotic, some of you have answered haloperidol. Yes, of course. Mostly this antipsychotics, olanzapine, haloperidol is being given for refractory vomiting. What is refractory vomiting? What is refractory vomiting? Already we have seen today itself.
Unmanageable vomiting even after giving antiemetics.
Yes, even after giving 1 or 2 antiemetics, if the vomiting is not controlled, we can go with this. Okay. Haloperidol is a typical antipsychotic. It's a pure D2 receptor blocker also. It can be given orally, IV, as well as subcutaneously it can be given. Okay, antiemetic dose is 1.5 to 5 milligram twice a day or 3 times a day by mouth, and 0.5 to 2 milligram IV every 8 hourly. And what's the maximum dose that can be given per day? Haloperidol, how much is the dose?
10.
It's 20 milligram. Okay, just keep in mind when you are dealing with this palliative care patients, you might need to give this haloperidol for controlling the restlessness or delirium management, everything. For anti-emesis, we need not to give such high doses. Even with 0.5 milligram or 0.75 to 1.5 milligram, OD or BD can manage the case mostly. But in some case, we may need to give continuous subcutaneous infusion. We may need to give. Okay, it differs with each case. But in case of when you are dealing with delirium and all, you will see this in detail. And olanzapine is another atypical antipsychotic that is multiple action on multiple receptors, D1, D2, D4, serotonin receptors, alpha adrenergic receptors, H1 receptors, and all. This is being used in refractory vomiting. Okay, its dose is 5 to 10 milligram per day by mouth. And levomepramycin is not being used in our settings. It is used in other countries, I hope. Antiemetic dose is 6.25 to 25 milligram twice a day, and 25 to 50 milligram per day. Can be given subcutaneously as well. Next. Corticosteroids, I have already explained why it is being given. The antiemetic dose is 4 to 8 milligram per day for chronic nausea, and up to 16 milligram per day for malignant bowel obstruction. Bowel obstruction we will see in next session. Okay. And octreotide, hyoscine, cannabinoids, and benzodiazepines also can be used as an anti-emetic. Okay. Next. And route of antiemetic. Mostly we prefer oral only. While we are starting an opioid, we can give an oral antiemetic along with that. Which antibiotic we prefer? Sorry, not antibiotic. Antiemetic we prefer while prescribing or while giving or while starting this opioid.
Metoclopramide, 10
Yes.
mg.
Yes. Why?
That acts on the mu receptor and the D2 receptor.
Yeah, metoclopramide acts on the D2 receptor. Okay. Yes. Okay, mostly we prefer the oral and antiemetic. But if the vomiting is not controlled, what we have to do is we should change the route of administration of these medicines. We should do. Why? The vomiting is the one condition which can affect all other symptom and all other intake of the medicine and all. Why? Because if the patient cannot take anything orally, excuse me. Okay, sorry. So if the vomiting is not controlled within 24 hours, then we should recheck whether the cause, whether the diagnosis is correct or not. And then we should change the route to IV or subQ. Okay, and suppositories also can be given. Sublingual, transdermal patches are available. In our settings, we mostly prefer subQ route or IV if it is not managed orally. Okay, next. And nausea and vomiting management guideline. We should document most likely causes and treat potentially reversible causes and exacerbating factors like drugs, constipation, severe pain, infection, cough, etc. And all these factors should be managed along with the treatment of vomiting. And we should review the dose after 24 hours. Okay. After reviewing the dose in 24 hours, if the vomiting, the frequency or the vomiting is not controlled, then we should review the cause, whether there is any hidden cause for this vomiting. Sometimes we may need to some investigations. In palliative care settings, yes, sometimes we may need to do that. And remember, 1/3 of the patients may need more than one antiemetic. And if on parenteral, we should consider converting to oral after 72 hours of good control to oral regimen. Okay. Hope it's clear. And pharmacological management, it's already told, haloperidol, metoclopramide dose. Haloperidol 1.5 to 20 milligram per day. Metoclopramide usually we starts with 10 milligram 8th hourly. Maximum of 100 milligram can be given, and sometimes when a patient is in continuous vomiting and all, we may give this metoclopramide along if the patient the reason for this vomiting is opioid induced, then we may give the continuous infusion of this metoclopramide subcutaneously or IV, 40 milligram sometimes or 30 milligram continuous infusion can be also be used. Or domperidone, ondansetron, diphenylhydramine, and octreotide, dexamethasone. These are the other medications. You can go through the dosage and all later on. These slides will be shared with all of you. And next. Yeah. With this, we are completing the discussion on vomiting and nausea and vomiting. I hope you all get some idea on this. So after this, we are going to see this constipation. Okay. What is constipation? Can anybody answer what is constipation? Somebody who doesn't answer can answer.
Not passing for the stool.
Yes, no passing stools. And what are the things we asked when taking history? We want to know whether the patient has satisfactory bowel. What are the questions we ask?
Does the patient pass stool every day?
Yes. Then
Type of the stool.
have
Is
we?
it soft or hard?
Yes, ma'am. Yes. Any other question?
Whether the pass motion is large amount or small amount, or
Yes,
their
ma'am,
stool
yes.
is soft or hard.
Yeah. Yes. 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 And okay. Any other question?
We can ask patient what you had yesterday and today. He is eating something or not. He's drinking water, or what he is taking or not. If the patient is not taking food because of vomiting or not giving any liquids and all, then they're not passed through. But we have
Yes.
to exam physically.
Yes. All these can be asked. Yes. We will see in detail what are the miss points and all. We will be seeing what is constipation, why it is important, and what causes constipation, and how to assess it. Okay. Next. Okay. As most of you have said, it is difficult or painful defecation. Okay. It is not only about the regular bowel pattern. It is about how easily they are able to pass the fecal matter. Okay. How difficult or painful defecation, and which is associated with infrequent bowel evacuation and hard feces. And we should check how it is different from their normal bowel pattern. And 45% of palliative care patients are constipated on admission. Okay. So the questions we usually ask is whether the bowel pattern is regular or not. Okay. For some people, it is once in every day they may be passing stool, or some people may be passing stools once in 2 days, or some it may be once in 3 days. That may be normal for them. Okay, then we should ask what is the interval? Okay, regular or irregular, that we should check on. And we should check on the consistency of the bowel, not bowel, fecal matter. Okay, whether it is hard stool, whether it is watery, whether it is, we will see the Bristol stool chart. Okay, you should use the Bristol stool chart and you can show to them, to the patient, and get an idea what type of stool they are passing. And all this gives an idea why they are constipated. If it is hard pellet-like stools, then that itself is the cause for constipation. And difficult or painful, whether they have to strain for passing stools. What might be the reason? The less intake of water can cause the hard stools, or even mass in the GI tract can cause, in the large intestine colon, can cause what? They might have to strain, or the presence of blood or mucus in the stool. Okay, we should ask. Okay, when the patient is presenting with this constipation, mostly we see this constipation with hemorrhoids, fissures, right? Fistulas and all, we see the blood-stained mucus, blood-stained fecal matter, right? So the presence of blood or mucus in the fecal matter, that is a warning sign, and that should be investigated and should take necessary management, right? So these are important. And what are these are the few points, and we will see in detail in coming slides. And next, symptoms, how they will be presenting to you. The feeling of incomplete evacuation, bloated feeling, nausea and vomiting may be there, abdominal cramps, bowel obstruction, overflow diarrhea, urinary retention, or they can be presenting with all these symptoms. Okay, they may not be presenting you as such as a constipation case. Sometimes the patient may be coming to the OP with the severe abdominal cramps. So after giving the pain medications and analgesics, if we are leaving the patient, the symptom will not be controlled after hiking the dose or regularizing the analgesics. What we should do is, when a patient is coming to us with a symptom, we should assess the bowel status as well as bladder status of the patient, sleep pattern, food habits, sleep pattern, everything, the pain, everything is important in case of, especially in case of palliative care, because all these are correlated. Some drugs itself can cause all these things, and vice versa it can happen. Okay, so the patient may be presenting with urinary retention, maybe on catheter and the urinary blockage. Sometimes the patient might have changed the catheter 1 month back, and they may be coming for catheter change, but for 2 days they may be having any urinary retention. So you will be giving a catheter change, and if you are sending him back, the problem will not be solved. So you should ask. If there is any urinary retention, you should definitely ask whether there is a history of constipation. And overflow diarrhea, we will see in coming slides. Next, causes of constipation. Yes, opioids, morphine, some of the antidepressants, anticholinergics, and some of antihypertensives, antiemetics, all these can cause constipation. So we should be very cautious in palliative care setting, because it is one of the most common symptom. So we should know the management, as well as the pharmacological as well as non-pharmacological measures we should know. And metabolic disorders, hypercalcemia, hypokalemia, uremia, dehydration. The patient may not be taking the food properly, or they may not be hydrating properly. So that itself can cause constipation. And diet, poor appetite, low fluid intake, fiber intake. Okay. And environment, they may be hospitalized. Okay. Or inability to attend the call. There may not be any caregivers. When they are feeling the urge, there will not be anyone to take him or her to the washroom. So that itself can cause constipation. I have seen some of the patient in my ward. They may not even take food properly. Why? Because the caregiver may be irritated, or a caregiver may be complaining. Why always asking for this, like that way? Or the bubble may be moving or more than one time. They might have to take the patient to the bathroom. So it is adding distress to the caregivers also. So we should see whether there is any factor, these type of factor also. Okay, When other causes are neurological, spinal cord compression, we know, we will see, I think you will get a session on spinal cord compression and sacral nerve infiltration. All these can also cause constipation. One of the major symptoms of spinal cord compression itself is urinary retention as well as this constipation. And structural, pelvic tumors, radiation-induced fibrosis, painful anorectal condition, intraluminal obstruction can cause constipation. Others are depression, weakness, immobility, inactivity, sedation, and age. Okay, next. Yeah. Why? Because this constipation itself can cause this abdominal pain, abdominal distension. We have seen this abdominal distension, it can stimulate the stress receptors and can cause nausea and vomiting. And urinary retention, it will cause the pain in the patient, and they cannot even take more fluid and all. And if they are in home and all, if there is urinary retention, that somebody should take him or her to the hospital immediately, right? So this constipation should be managed properly, and we should prevent our patient from getting this constipation. That is what we should aim at. And confusion, delirium. Yeah, some of the patient may present to us with the delirium. They may be having disoriented speech and all, and on asking the history, we might know that they have this constipation. After managing the constipation, I have seen many cases who is coming back to normal. Okay, and next. One more. Yeah, what this morphine is doing. Okay, we know morphine will cause constipation, right? We know why this morphine, now you have already seen why this morphine causing vomiting. Now here, why this morphine is causing constipation. Okay, by decreasing the propulsive intestinal activity, it will cause bowel stasis. That is, it will decrease the peristaltic movement or propulsive intestinal activity, and there will be stasis. So there will be more time available for water reabsorption. We know the function of small intestine and large intestine. Some percentage of this water is reabsorbed in the small intestine, and major portion of this water is being reabsorbed from the large intestine. So when there is more stasis of this bowel, the more time will be available, and there will be hard fecal matter, and there will be fecal impaction. Also, this morphine will reduce the or inhibit the secretomotor neurons. So less fluid enters the gut. So all these factors will cause fecal impaction. Okay. So along with this morphine, by default, we have to give a laxative as well, along with the opioid. Not only morphine, for all opioid. Okay, next. So this hands that chart opioids should chart laxatives. I have many sisters here. When a doctor is is prescribing this opioids, if we even miss the laxative, they used to remember us. They make us to chart the laxatives along with that. So you are attending this course here, and after completing this course, definitely this palliative care is just evolving only. Nobody. Okay, so if anyone is missing that, then you should definitely give a suggestion for giving this laxatives along with the opioid. Ultracet, which is the content is tramadol as well as paracetamol. So it is mostly given for as an analgesic. It is being given. So when this Ultracet is being given in your setting, you should give an opioid. Not opioid, you should give a laxative. Okay, or this tramadol, fentanyl, anything, it is we should give a laxative as well. Next. Yeah. What we should assess is what is normal for the patient. I have already told, for some patient, passing stool in the daytime or morning hours is the normal. For somebody, it is mostly in the evening hours, it is normal. Maybe once in 2 days interval. For someone, for somebody, it may be on all days. They should be evacuating that bubble. And the frequency, amount, consistency, everything is important. We should ask these things in history. And when was the last bubble movement? It is one of the most important questions we should ask. Okay. And is the patient experiencing any abdominal discomfort or cramping, nausea and vomiting, or excessive gas or rectal fullness? All these we should ask. Sometimes patient may tell that, okay, they are having regular bowel movement, but we should check on that whether it is satisfactory or unsatisfactory. Okay. And does the patient regularly using laxatives? If there is constipation, if you are identifying that there is constipation for this patient and you have already prescribed the laxatives, we should again make sure that they are taking that laxatives. In our settings, we used to give laxatives along with an opioid, but some of the patient, even after giving this caregiver education, the patient education and all, they may not be taking this laxatives regularly or at the prescribed dose. So we should not blindly believe the prescription. We should make sure they are taking these medications properly at the right time and at regular intervals. Okay. And what medications are the patient on? Is there any medication which is causing this constipation, whether it can be switched on to other or whether it can be changed? That can also be dealt with. And is constipation a recent change, and what type of diet is the patient on? We can advise more fluid intake as well as fiber rich diet. We can advise adding more vegetables to the diet, fruits to the diet. All these can be advised. Next. What are the common issues we face is when a patient is brought by the caregiver with constipation for more than 7 days and all, the patient may be in EOL. So the caregiver may be telling that he's not taking any food at all. So how he or she will pass motion? It is normal. Like that way they may be telling. Or in other hand, they may be presenting with diarrhea, overflow diarrhea. And when we are suggesting enema and all, okay, we will deal with this how the management of overflow diarrhea, so that you all will get an idea. So these are the questions we face. So when a patient is being presenting with overflow diarrhea, we might need to give enema. Okay. And in the first case, what we should educate the caregiver is, what we should tell them is, even if they are not taking any food, okay, millions of cells are being shed from our body in day-to-day basis. So the major bulk of the stool is the byproduct of this bacterial action as well as the shedded epithelium. So that should be evacuated from the body at least once in 2 days. Okay. So we should tell them, even if they are not taking fruit on a regular basis, or if they are not taking large sum of food, there will be some product that should be excreted out of the body. If it is not done, then they can harden up and they can block the bowel, and the newly formed bowel cannot be evacuated. Okay, next. This is the Bristol stool chart, and hope some of you may know. And this is the here from type 1 to type 7. The shape of the fecal matter, it is being represented, and all this has importance. The hard pillar stools indicates that there is some issues. There may be more bowel stasis, or they may be not drinking water properly, like that way. Watery, whether it is watery, whether it is foul smelling, everything. Okay, next. And coming to the management, we should correct the correctable. We should advise the use of laxatives and improve the general condition of the patient. Symptom control, we should concentrate on, encourage activity as well as fiber-rich diet. Next. Yeah. Coming to the non-pharmacological measures, first we should do a daily assessment. If the patient is being sent to home, then we should ask the caregiver to check on to that. Okay, to monitor the bowel pattern and all. And we should promote the mobility of the patient. If they can be mobilized, that can be promoted, and accessibility to the toilet facility or their ability to go to the toilet, that should be assessed. Why? Because sometimes the patient may be bedbound, or that may be, or CVA, or sometimes that attack may be recent, and they prefer to go to the toilet by themselves, and they may only prefer that. So what we can give a suggestion is, we can advise a commode chair near to the bed, so that they can get a privacy, as well as they can they will also feel comfortable. And the timing and privacy is also important. You might have known, to keep a particular time is very important. Okay, we can advise that, as well as the privacy is also important. When a patient is being hospitalized and all, and when a patient cannot go to the toilet area by himself or herself, so all these affects with the privacy and all. And when this commode chair is being given to their bedside, we should make sure they are okay with that. Okay. And taking this warm water in the early morning hours, and the squatting position itself can cause, or itself can help with the bowel evacuation. Okay. And there should be some caregivers if they cannot access to the toilet area by themselves. So we should give caregiver education as well. And diet and fluid intake and attention to other symptoms also needed. Next. And you all might have done rectal examination, right? What is the position we prefer? We will make the patient to lie down on left lateral position with right knee lifted up towards the chest, right? And we must use lubricants. Otherwise, it will be painful for the patient. Okay, next. And in rectal examination, if the rectum is empty and collapses, that indicates a functioning bowel. If the rectum is empty and dilated, while we are inserting the fingers inside the anal canal or rectum, we will get a feel, right? Whether it is empty, whether it is collapsed, whether it is dilated, whether it is ballooned, or whether something touching, the fecal matter is touching, whether there is a tumor mass, we will get a feel, right? So we should interpret accordingly. If it is empty and collapsed, it is normal. And if it is dilated, there is some bowel in the, there is some fecal matter in the bowel. And if it is balloon, that indicates that there is a gross constipation. And fecal matter in the rectum determine the consistency as well. If it is hard stools and all, then we can do the digital evacuation. If it is soft stools and all, we can give the suppository, or any, if it is chronic constipation. Okay. If a tumor, then definitely we should suggest them to take further opinion. Right. Okay, next. Classification of laxatives. There are many laxatives: stimulant laxatives, osmotic laxatives, bulk forming, fecal softeners, and bulk forming is plug, and then fecal softness, liquid paraffin, you might have seen. Osmotic laxative, lactose, it is quite common. Syrup loose, it is mostly given in most settings. And the stimulant laxatives, bisacodyl, as well as sodium picosulfate, senna. These are acting in, bisacodyl is acting in small bowel, and large bowel, sodium picosulfate is acting. And other prokinetic agents, metoclopramide, can also be used. That will increase the peristaltic movement and will help in bowel evacuation. Okay, next. The bulk forming laxatives, we mostly not prefer in our palliative care patients. Why? Because more fluid intake we should promote, and they may not be taking more fluid, and that is the one reason. And this it will increase the fecal mass, as well as thereby stimulating the peristalsis. The stool will be bulkier, and it will make the bulkier and soft stools. Okay, next. And osmotic laxative, it is lactulose. These non-absorbable sugars that will exert an osmotic influence, causing water retention in the lumen. Okay, and it will make the stool soft and thereby causing bowel evacuation. And it can cause dehydration. Why? Because it has an osmotic effect, and it may reabsorb this water, and it may cause water retention in the lumen, and it can cause cramping and nausea as well. Okay, next. Fecal softeners, it is liquid paraffin. Not used alone as a laxative, better to combine with the stimulant laxative. Why? Because it will coat the stool and will make the stool it will make easy for the stool to pass through the bowel. Next. And stimulant laxative is bisacodyl. It has a direct action on mammary plexus and submucosal plexus, has both motor and secretory action, and it should be avoided in complete obstruction. Why it should be avoided in complete obstruction? Can anybody answer? When a stimulant laxative, when it is being given, what can happen?
Perforation.
Yeah, perforation can happen. Okay, incomplete obstruction. So we should see the bowel sounds also when a patient is presenting with chronic constipation and all. We should rule out intestinal obstruction. Okay, next. Model prescription is first we should start with the stimulant laxative, and then we can add one or two as a step 2. We can increase the dose of that stimulant laxative to twice daily along with the softener, and as a step 3, we can again increase the stimulant laxative dose to thrice daily and along with the softener, and other rectal measures can also be taken as a final step. Manual removal can be done, suppositories can be given, or low or high enema can be given. While we are giving this suppository, while we are placing suppository, we should keep in mind that it should touch the rectal mucosa. We all know why. Why? Because it should act locally, right? If we are inserting it inside the fecal matter, then it will not have any action on the bowel. So it should gently touch. We should lubricate the suppository. There are patients who present with fissures because of this suppositories. So we should be gently placing the suppository. If we want, we can use the lubricant as well. Okay, it should touch the rectal mucosa, then only it can act locally. Next. And spurious diarrhea or overflow diarrhea. Okay, so what is that? It is usually misdiagnosed as diarrhea. And what is the symptom, or how they will present? Yeah, since we are running short of time, I will just explain. They may be presenting to us with diarrhea, but that is passage of foul smelling liquid feces. But on asking the history, when we are dealing in detail, we may get a history of constipation for more than 2 weeks, or even a month, or more than 7 days. Okay, so when this happens, when a patient is not having bowel movement for more than 3 days and all, there is stasis of this the fecal matter inside the bowel, right? So what happens is the stool get hardened and it will be impacted in the large bowel. So newly formed bowel newly formed fecal matter cannot seep out or come out because of this obstruction. So in coming days, what will happen is the water, most of the water content will be coming or seeping out through this, and we will be seeing that as passage of foul smelling liquid feces. Some of the fecal content also may be there. Okay, so what we should do is we should definitely ask them when a patient is coming to us with a diarrhea, especially in palliative or in other settings. We should ask them whether there is a history of chronic constipation. We should rule out that first. and the bowel pattern should be checked on. And we should do a parectal examination and digital evacuation, followed by enema we can give, as well as regularization of laxatives can be done. And enema we prefer, high up enema we prefer. In our settings, we use suction catheter to give the enema. Okay, phosphate enema can be given, but be given high up. Usually we give in the lower end, but it has an action on that end only. But when the fecal matter is impacted in the higher end, we should give a stimulant action, or we should give the enema by using a suction catheter in the higher up. Okay, so is it clear for all of you? So anybody has any doubt on this? Okay, next. Coming to the conclusion, constipation is a symptom, it's not a disease. And no laxative works if you do not give enough or you do not give it at all. Okay, we may need softener as well as stimulant laxative. Okay. Next. And this is the case. And one more. Okay, you all can go through this and answer. What are the issues here and how would you investigate and how would you manage? I will tell the issues. Okay. The patient is having gastric adenoma and she's on chemotherapy and she's having vomiting, abdominal colic, fever. She has incomplete bowel movements and all. Okay. What can be done for this patient? The medication is not given, so you can give the suggestions. I hope all of you got some idea on nausea, vomiting, and constipation. I hope all of you can answer this. Yeah, I know it is not, this case itself is not complete. So if the patient is on any analgesics, okay, if the patient is an opioid, then we should do what? Yes, rectal examination we should do first. Then all of you can answer.
Check the bowel movements.
Yeah.
Blood report.
Urinary tract infection increased, lots of fluid taken.
Yeah. Yeah, I will answer. What we can do is, here she has vomiting, she has abdominal colic and fever, right? The fever and all may be due to the urinary tract infection and she has incomplete bowel. What we should do is
maintaining.
Excuse me, ma'am.
IV fluids maintaining, ma'am.
Okay. Yeah, we should do a parectal examination and we should see whether there is constipation. This constipation itself can cause abdominal colic as well as vomiting, right? So we should check onto that and we should do the bowel evacuation and we should regularize the laxatives and all. And that itself can reduce the vomiting as well as the abdominal colic. And we should revise in every 24 hours. If the patient is being admitted, we can give IV and IV route if it is available. If it is multiple episode of vomiting and all, we can give it IV. But once vomiting is controlled, we should come back to this oral medications and all. Okay. If all of you have, I think it is clear for all of you. And if there is any doubt, you can come up with in the other session, the coming session.
Sugar Maggie, sugar.
Thank you, ma'am, for the detailed session. Anybody have any doubts? So we have only 5 minutes. If you have any doubts, please ask.
Ma'am,
Yeah.
Yes.
can I ask for nausea and vomiting, is it okay if we ask patient to try eating sour fruit or dry lemon skin as the non-pharmaceutical measures?
It's not clear for me. What's a non-pharmacological measures? What?
Instead of maybe before they try medicine, can they try to take some sour fruits to
Fruits,
help?
okay, fruits, okay.
Yeah, with the nausea.
Yeah, citrus fruits and all, if they have nausea and all, we can suggest that. But merely giving this suggestion may not relieve the symptom. We should see what is the cause of this nausea and vomiting. If it is opioid induced, by merely giving the suggestion of taking these fruits may not help her. Okay. And if it is chemotherapy, if it is due to this chemotherapeutic agent, or if it is due to radiation, or if it is due to any constipation, we should do that management. First thing what we should do is we should identify the cause of vomiting. Okay. If it is, yes, Shiva sister, would you like to
Yeah.
add on to that?
Yeah, so I think if they have a gastritis, if the patient is having a complaint of gastritis, that would not be a good idea for giving cities like that kind of the foods. So it will increase the gastric irritation, and again the patients will coming with the nausea. So I think you have to if they want, you can give some, but don't give big quantity. So that is the suggestion from my side. Usually, if you suggest give some the fruits like that, so the caregivers might be thinking like, oh, that is the best food. So they will be giving a concentrated quantity of that kind of the fruits. So again, that will irritate the gastric mucosa and develop gastritis. So if they prefer, you can suggest few, but otherwise you don't. Always, as ma'am said, you have to identify the cause first, then you have to manage, especially nausea and vomiting. So maybe sometimes you might be thinking about the major causes. Sometimes it might be because of cooking smell. So you have to just, whenever the patient comes to you with nausea, vomiting, always we will think about the drug management. Instead of that, you have to think about the non-pharmacological management and identify the cause. Then you can talk to the caregivers and manage like. So I think time up. So we will wind up now. Thank you, Greeshma ma'am, for the detailed session. Thank you, friends, for making this session very interactive. Thank you. Thank you.
Yes, thank you all.
Thank you everyone for joining in. See you in the next session. Till then, everyone take care. Bye-bye.